Hello, everybody. Welcome back to the Incubator Podcast live at Hot Topics in Neonatology. We are graced with the presence of Dr. Ravi Patel in the studio. Ravi, welcome back to the show.
Hey, Ben. How are you? It's good to see you.
It's good to see you. For people who are not familiar with who Dr. Patel is, you're a professor of pediatrics at Emory University and Children's Healthcare of Atlanta. You direct the neonatal clinical research and lead statewide quality efforts as the chair of the Georgia Perinatal Quality Collaborative. You've helped shape how evidence is generated and implemented in our field, where you work with the NICHD Neonatal Research Network, and your leadership role both nationally and internationally. You've participated in a variety of ways to the conference. You were part of the quality symposium yesterday, and you're going to give a talk during the 3 days of the conference called "When has enough evidence accumulated to guide practice? Do we need another trial?" I think this is a question that we're all wrestling with, especially when we have, as new evidence comes out, sometimes we're very eager to implement it, but the question really has to be asked, when has enough evidence? What is your take on and remind us what you spoke about at the quality symposium?
Yeah, I gave the talk yesterday, kind of tied together in the theme of yesterday's talk was the tension between quality improvement and evidence-based medicine. And the idea is, if you think of quality improvement as a tool to implement evidence, you want patients to receive good care. What is good, appropriate care? What's the right thing to do? How do we know? And when are we certain enough to know that we should standardize, implement? So the tension talk was about sometimes the challenges with, when we don't know what's right, should we just standardize? Or is that problematic because you might standardize the wrong thing, and 10 years later you find out that was actually the wrong decision. And so that was the talk yesterday was a little bit on that tension. I think there's a lot of harmony, quality improvement, being used to make sure patients receive the care we want them to receive, making sure that we translate evidence into practice. But then sometimes we get a little ahead of ourselves where the evidence isn't so certain and we still want to kind of test, implement, and I think we have to be a little careful about it.
Yeah, a lot of the time we talk about the evidence as this bystander that's over there, but we don't do the introspective work. And I think that as groups, we should potentially look at what we are doing. And I'm wondering what you think about that, where if you're a unit that is looking to improve on something specific, then your approach is going to be very different from a unit that's doing something quite well already, irrespective of the particular measure we're looking at and the particular intervention. Because you have units sometimes that do certain things or have certain types of bundles maybe, and you look at the individual items in the bundle and none of them independently have a meaningful effect or an independent reduction in risk and so on. But together and with this group, it leads to better outcome. So I think there's this tension that you're talking about between the evidence and our practice. What do you think about that specifically when you look at what is good for and for whom?
Yeah, that's a great question. I think we should put a lot of energy into making sure the things that we are fairly certain are good, like baby receiving antenatal steroids before delivery, that's
Yep.
preterm, attempting delayed cord clamping, the things that we know and we're fairly confident are making sure those things happen. And we should really there's only so much capacity in a given NICU, only so much energy that can be applied to these improvement processes, and putting energy on those things that are kind of we want to happen. And then I think maybe not putting as much energy on just efforts to standardize this, and we need a protocol for this, and we need a guideline for this, and it kind of becomes this endless list of things that we need, that we're always working on, and we put a lot of energy on that. And sometimes as we do that, there's only so much kind of capacity that we may then offset some of the energy on the things that are really important, and they may not happen as much as we want. So one of the things I touched on yesterday was about kind of reliability in healthcare, and for a lot of the processes, we're either in chaos or at level 1 reliability. They're happening 80% of the time, but very few things we want to do happen 95, 99% of the time. And if we really want the very kind of big dot measures, NIL steroids as an example, we really should put a lot of energy on that. And maybe to put that energy, we have to, give somewhere else. And some of that kind of giving somewhere else is the efforts we'd sometimes use on standardization and protocols on kind of low certainty, very low certainty evidence.
You mentioned in your presentation that really the evidence and how it is collected can really introduce certain uncertainties and biases, and And sometimes we tend to forget about that. I think that if we see a paper and it's peer reviewed and it's in a decent journal, like, all right, this is good enough. But we miss on these inherent cracks in the evidence that potentially can have pretty significant ramifications. How do we need to rethink a little bit about the evidence?
Yeah, I touched on a little bit of kind of how certain are we, and I think we're sometimes uncomfortable. Clinicians don't like uncertainty, and we need to become more comfortable with the idea that we have to make decisions during rounds. We have to, choose what we're going to do, but we should acknowledge that we're uncertain about certain things that we do, and that degree of uncertainty. If you use grade, for example,
Yeah,
in terms of the spectrum of being very certain, high certainty evidence, or being very uncertain, very low certainty, that the high certainty things we should do always, but for the low certainty, it may or may not be the right thing, and it may depend on context, values, preferences, the patient in front of you, and maybe that's not where we should standardize things. And I think as we think about that spectrum, using tools like grade, that's commonly applied as part of Cochrane reviews, for example, that allows you to get a sense of, how certain should I be? And at the end of the day, we do have to kind of make decisions, move on. We also know that, staff in the NICU like consistency. So there
yeah,
are values with kind of, not having chaos and lots of variation, but we should be thoughtful about the things that we really are want to standardize, because you always risk standardizing to the wrong thing. So
yeah,
if as a trialist, there's three outcomes of a trial. It's either no difference, or the intervention you're testing is harmful, or it's beneficial.
yeah,
And if it's either harmful or there's no difference, you're probably not going to do it. And if it's beneficial, you probably want to know, like, well, how beneficial is it? And if it's a small benefit, you may also say, I'm not sure it's worth the resources or the cost. And the probability across those kind of chances are that, there's a good chance that this thing that you think is going to work may not do anything.
yeah.
And you're putting a lot of energy and time, and you're adding to task saturation in the NICU. Maybe we should be really thoughtful about saying, I'm not so sure that there's a lot of evidence. Maybe we should just let it be and not kind of try to standardize that. That's kind of the gist of that, the talk yesterday.
It's interesting how our field has evolved, right? Because I think that early on in the infantile years of our neonatology, we used to do a lot of things with zero evidence. Basically, whatever made sense or whatever we had gathered from adult medicine, we did. And then the era post William Silverman of, like, we need to do randomized control trial, like we need to test interventions on randomized control trials. That's really led the way for the trial era. And now we're in a phase of our field, of our maturation, where it's hard to continue doing trials the way we used to do them. Where are we going?
Yeah. I kind of ended the talk yesterday with this really kind of call to say, we really need to kind of prioritize, re-energize efforts in evidence generation. It's kind of maybe not top of mind like it was maybe the Bill Silverman era.
Yeah.
We need to generate evidence, because if you're a quality improvement person, you want to find the things that we should be doing, and then you have all these tools and methodology to make sure it happens. But if you don't know, it's kind of, it's a challenge. And I think, when you look at kind of Vermont Oxford network data, where we've really stalled in improvements in a lot of the kind of common morbidities, and maybe we're at the point where we really need to think about what are the new things we might learn and be able to do and apply.
Mhm.
Um, so, tomorrow I'll be touching on kind of in a methodology session about kind of when has enough, do we need another trial? How do we think about certainty? And it's going to be kind of a session about platelet transfusions and,
Yeah, you're using the platelet transfusion trials as an
oh,
example of
yeah,
yeah.
exactly.
But I think that also, I don't know what you think about this. It feels like in our field, we tend to think of ourselves as people who will not implement anything until the right amount of evidence is there. But in reality, we've adopted a lot of practices with zero evidence.
Yeah.
I was giving a lecture this morning on Eat, Sleep, and
Mhm.
Console, where we thought this sounds pretty good. The outcomes seem pretty okay, and we just ran with it. And now the evidence has to sort of catch up to the field. Kind of what the same thing has happened in the past with caffeine, and Barbara Schmidt explaining that, like, yeah, the evidence had to catch up with the field. So, um, what do you think about this idea of um, physiology based medicine, where we say, hey, like, this makes sense. I don't need that much evidence. I'm gonna just start doing that.
Yeah, that's a great example. I think Eat Sleep Console is a great example of how this which was really a QI project.
Yeah.
It started as a QI project. Somebody said, we should just, what do babies need to do? They need to be able to eat and
Yeah.
sleep and be consoled, and we're just going to focus on that. To the credit of NIH, they said, we really should test this, and they did a very, kind of cool trial in terms of saying, if you're going to adopt this, let's use a planned experimental design. Let's use a stepwise cluster trial where we randomize centers in a way that we can understand if everybody's going to adopt this, we can at least test
Yeah.
over time, and it confirmed the benefit. And we can be a lot more confident now that this is probably the right approach short term. And, they presented some of the long-term follow-up at PS this year that also supports eat, sleep, console. Um, we do sometimes get ahead of ourselves. Caffeine is a great example. And, what would have happened if the CAP trial showed harm with
Yeah.
caffeine use? Are we gonna, at that point, is it too late to de-implement? Or, um, there is always this desire for innovation, and maybe there's a value in terms of just variation. So some people adopt a practice, some people don't, and it does allow us to kind of, evaluate and study that. I do think for those places that say, well, it's uncertain, but it's worth a try. If you can do it systematically, where you measure your outcomes, you study it, or if you do it where you say, we're going to try this, but we're going to also realize that the evidence is uncertain. So if new things come out, we're willing to
Yeah.
change. And the hard part is when we just are so convinced on low certainty evidence, and we're like, this is the right thing to do. And then when kind of evidence changes, it's hard to kind of de-implement or change practice, or just becomes ingrained.
Yeah.
And so I think that's the hard part. And across the spectrum, as there is, variation in almost everything we do. There's going to be the kind of early adopters, the innovators who might do things later, and the laggards. And I think that's probably a good approach. But maybe the laggards have some sensibility of saying, I really want to be confident before I do this for every
Yeah.
patient all the time.
Absolutely. My last question for you, obviously, is a follow up to that, and I think that this uncertainty is a wide open invitation to actually practice better shared decision making with families. I know Dr. Mitra has done a lot of work with that. How do you what do you recommend in terms of we feel very uncomfortable with our
Mm.
uncertainties, and when we are uncomfortable, we definitely don't want to have conversation with parents about how uncertain we are about what we're doing. When in truth, the parents want that. They prefer honesty. There's been well documented that parents prefer if a clinician says, "Hey, I am not certain," but how do we merge the two and make this marriage happen?
Yeah, Shovik has done a great kind of example with the use of, prophylactic medicine of kind of values and preferences. That's really important, I think, in terms of if you think of the certainty of evidence, and then what would parents want? If you look at, let's say, prevention of IVH as an example, families are pretty clear that this is an important outcome
Yeah.
they want to prevent. And they would, if you asked them, they probably would say, yes, I would want that. Even if clinicians may be uncertain or concerned about maybe, some of the uncertain about the risks, and maybe the kind of higher number needed to treat, or whatever the reason is that they don't use it. I think having those conversations allows you to kind of balance, I think, the values and preferences of families with the evidence to get to what you would want, which is kind of integrating that into practice. And that's the ideal. It's hard. It's, I think, very hard to do. You, as a clinician, have to be very comfortable with what the evidence shows to have that conversation with families, and families then have to kind of at least know what they might want, or you have to infer what they are telling you to then guide, should I do something or not? And it's hard to put into practice, but I think when we standardize it, often when we kind of take away some intentional variation, you lose that opportunity to, you know, get what families say. Take systemic steroids, for example.
Hmm.
You could say, this might not prevent long term, might not prevent BPD, but might help your baby get extubated. And some families might say, well, if it's not, I'd rather just kind of wait, and I'm okay with, being on the ventilator. Others would say, yeah, if we can get off the ventilator, I want to,
As soon as possible.
I think we're okay. And, engaging that can help you make, I think, as opposed to just saying, we're going to use this standardized approach across patients.
That's very interesting to think about it in those terms, that the family may actually help you and comfort you in the decision that you're taking. So very cool stuff. Ravi, thank you so much for dropping by. Congratulations again on this body of work.
Yeah. Thanks, Ben. It's good to see you.
Yeah, good to see you.